Hi, everyone. I'm Dr. Vandana Katyal. I'm an orthodontist from Sydney. And today I'd like to share clinical pearls and tips that I've learned in my clear aligner treatment journey. I've been an orthodontist for over a decade and I do a lot of aligner treatments. So I've worked out a systematic workflow for me to be efficient and to be consistent and to get good results. And this systematic workflow is what I'm going to talk about today. I'm going to share with you my 9 steps that I use. It's like a checklist on how to plan when it comes to clear aligner treatments. This checklist will also help you communicate with the technician and be able to think about the treatment that you're doing, think about the biology of the patient, the forces you're going to apply. And it kind of takes you back to a bit of diagnosis as well, because planning and diagnosis go hand in hand. So I hope you enjoy this video, and please feel free to hit the like or subscribe button. Also hit the bell button to notify you every time I post a new video. Let's move on. We're going to cover clear aligner planning philosophy. We're going to cover technician communication, why it matters. I'm going to walk you through my checklist step by step of the 9 steps. I give you tips for common clinical scenarios, and we're going to possibly have a discussion in the comment box later on if you have any questions. So, thinking about what makes a successful orthodontic treatment, I think there's various factors. Just because I give you this lecture and I give you a checklist or some tools doesn't mean that you are going to be able to get those results. So let's think about why. Well, firstly, you've got to have strong foundation in diagnosis, right? That's your record taking and analysis of those records. Then you've got to have a strong foundation in working out a differential diagnosis. You need to know your scope. You need to work within your experience. You need to understand case complexity, treatment planning, and understand troubleshooting. All of these will lead to success. So, this is a multi dimensional problem when it comes to orthodontic planning. So, developing your expertise, skill, and experience in all those areas is very, very important. Back to the basics. Now, this is from Graeber's textbook, where Profit has come up with his envelope of discrepancy. Now, this sets the parameter of what is biologically possible. Often I get asked a question of, can we move teeth about 2 millimeters, or in adults or in children, how much can we move teeth? And here's your answer. So Profit's given us some basic guidelines. I use them as rules of thumb of how much movement is possible in an adult versus a child versus surgery. So this gives you a really good overview of the possibilities of scope of movement of teeth in various age groups. We also need to understand variability. Okay, so orthodontic forces will not have the same response, even in closely related beings. So we have to understand that there's a large variation here. So when we apply simple theories of forces and moments, it doesn't apply biologically or at the clinical level. We also must understand the basics of creating space in an arch. Often orthodontics is done to resolve crowding. So we have our 5 major ways: extraction, incisor proclination, upper molar distalization, interproximal reduction, arch expansion. But we also have minor ways, like maintaining leeway space of Nance, derotations, uprighting of teeth, and lower molar distalization, which is fairly complex. We also have to understand that the accuracy in clear aligner treatments vary. So how do they vary? The material and thickness of a liner. Nowadays, we have so many aligner companies. The shape and position of your attachments, the amount of activation, the velocity that we have in an aligner system or in a treatment. Patient's own bone density and morphology is important. The anatomy of the teeth. What is the surface area? Are they short clinical crowns, long clinical crowns? What is the patient's age, case complexity, and your own experience? We also know from a culmination of accuracy studies in clear aligners that we have a variable accuracy when it comes to adults. Now, a lot of this data is from adults, and I've kind of aggregated this in a table form to make you understand that lingual tipping of incisors with clear aligners is highly predictable, highly accurate. Intrusion of anterior teeth and upper molar distalization, again, a very high accuracy. But if we look at the bottom of this table, you see that the mesiodistal rotation of canines and premolars have very low accuracy. So is a lingual root torque. Okay, so understanding these parameters also helps us give the right instructions and do the right type of thinking of, are we going to overcorrect or not? Or do we need attachments for certain scenarios or not? So this is important. I just note that we have more data currently in adults than in adolescents. So we have to take that into account when we're doing our treatment planning. So why should we do a step-by-step workflow checklist? To be honest, I'm someone who's not a fan of cookbook techniques. I do not like cookbook techniques, but I do like systems. I think systems help you a lot. Number one, they provide a medical legal record. So your systematic thinking becomes a medical legal record. It promotes consistency and clarity within your own patient base, within your own treatment planning, within your own surgery, but also for the aligner technician. It's going to avoid your unnecessary revisions back and forth, really saving you lots of doctor time. Increased efficiency. You should really be approving that second plan or first plan if you really do it right, and avoids distractions. A lot of times, algorithms and softwares will show me movements, and it makes me believe that it's possible, but it's not. So when I use my grounding and foundational principles, I know it's not. So I'd rather avoid those distractions. So I have a systematic planning approach, and we're going to start step by step. So the very first thing I'm going to tell you need to think about when you're planning a case, you've got to set the transverse dimension. So you've got to visualize what is the final smile width and the arch form. So things that you'll have to consider here: do you need dental expansion or skeletal? What is the gingival condition? Do we have a thin biotype? Is there existing recession? Do we even have buccal bone? Wala ridge. I love using the Wala ridge, which is like a ridge that where it's the most buccal limit of the dentoalveolar bone, right? It gives you like a rule of thumb or a general guideline as how much you can expand. And also the inclination of posterior teeth. So the more retrocline or more lingually tipped teeth are, the more likely you can increase space by expansion of the arch. So you've got to think about, do you require changes? That's another thing. Do you really have to change the arch form? Yes or no? And if so, by how much? And where? And do you need, as you're expanding to counteract the biomechanical side effects, do you need to put some buccal root torque on your upper posterior teeth, particularly the molars? Do you need to expand second molars? Often we will exclude them in expansion or include them. It's an important decision to be made. After I've set my transverse dimension, I'll often think about my vertical dimension. So, for example, the first thing that you're going to look at is the incisal display on smiling, right? So again, age is a big factor here on setting the final goal. What is the incisal display on smiling? That is very important. So are you going to intrude or extrude the anteriors? Are you going to intrude or extrude the posteriors? Are we going to utilize growth here, which is relative anterior intrusion? Or we can correct overbites with incisor proclination, or vice versa, correct mild open bites with incisor retroclination. Okay, so these are the decisions to be made. If you made a decision to change the vertical dimension, well, what are the appropriate attachments here? Which teeth are extruding? Do we need any bite ramps? Is there evidence for the use of bite ramps? What is the predictability? We know intrusion is more predictable than extrusion with clear aligners. And what's the biologically plausible final overbite? Can we really get ideal overbite in a 50-year-old who has severe deep bite? Can we do that? Is it biologically plausible? Once you've set your transverse and vertical, step 3, sagittal. So we're going to look at, hey, are we going to correct canines and molars? If so, are we correcting both? Is this Is age a factor here? Are we correcting just dental class 2 or skeletal? Where's the midline? Is there asymmetry of the midline? What is the severity? And do we think the treatment time that is valid for this type of treatment? For example, sometimes I'll make a decision to leave a half unit class 2, a half unit class 2 in an adult because they simply want anterior alignment. So treatment time is a consideration here. So one of the things with sagittal, you're defining the buccal occlusion. So you've got to ask yourself, are changes required? Yes, no. What is the finish like? Is it a class 1 finish? Is it canines class 1, but the molars class 2? So you've got to start defining that. Which midline do you want to shift? Is the upper coincident to facial? So we're not going to shift that, but shift the lower. Elastics planning, often with sagittal treatments, we'll think of interarch elastics like class 2, class 3, and distalization of molars to correct a class 2, especially upper molars. Are we going to take it sequentially, or we're going to distalize en masse? There's a lot of theories and research behind this. So I'm simply giving you a checklist. For example, can we mesialize? Sometimes you have to do maxillary mesialization in case of upper missing incisors. Smile arc is my step 4. I'll look at, once I've decided my transverse, sagittal, vertical and sagittal dimensions, I'm going to start looking at the smile arc now. So here I'm starting to define my microaesthetics, my leveling. So I'm thinking, okay, do we need a change? Do we need to level the incisal edges or gingival margin? Which teeth we're going to maintain? For example, a 1-1 could be in a perfect position. So I want to maintain the 1-1, but match the 2-1 to the 1-1. Are black triangles predicted or present? These are the considerations that I will start taking. After that, I'll think about my space. So step 5, how am I going to alleviate crowding? Remember, we talked about the 5 major ways and minor ways of creating space. So in this case, we actually extracted 4 premolars. You can see it's a severe crowding with a transposition. And this case was finished completely in aligners. There was no braces used. It was simply with using interarch elastics and clear aligners and extractions. In certain cases, we're using IPR. So the case you see on this slide is actually completely resolved with interproximal reduction. We did not need to extract here. Sometimes we'll do upper arch distalization, okay, to create the space. So there's many ways of alleviating crowding. Incisor proclination is another one. Once I've decided all of those, my step 6 is the final outcome. It's really important to tell the technician or communicate with the aligner technician, what do you see at the end? What do you visualize? And they must be biologically plausible goals. Do you visualize an overjet of 1 to 2 millimeters and an overbite of 15 to 20%? What do you envision in your buccal occlusion? What about the occlusal contacts? Do you want heavy contacts on your posterior teeth, perhaps, because you're trying to extrude them? Or do you want light contacts on your posterior teeth? What is your interincisal angle at the finish? So you're setting your root torque or incisor labiolingual angulation. This is an example of occlusal setup at finish. Now, this is for a growing child where we're doing a lot of extrusion of the posterior teeth and using the dental alveolus development, vertical development to correct the deep bite. Once we've decided all those steps, we're now starting to think about attachments. I suggest that you think of attachments at the end because now you've set your goals. You know which teeth are intruding, extruding, which ones are being maintained, what are the changes you're after. Now we're going to design the appropriate attachments to create those movements. There's also another video that I've done recently that talks about attachment size and position, and I think you'll find that beneficial. So I'll leave that in the description box below. So one of the things I'm thinking when designing an attachment, do I do a vertical or horizontal placement? Are we placing it middle of the tooth? For example, in premolars and molars, I'll often place attachments middle of the tooth where the surface is the most convex and the midpoint is usually the best point to deliver aligner forces. But when it comes to anterior teeth, sometimes I will position it more incisally. What is the size? How big your lever needs to be? Is it just 2 millimeter enough? 3, 4, 5? How big a lever do you need? How big a force system you need? Then we've got some special conditions we've got to take into account for each individual patient. So this is called maximizing it, juicing it. You've been given lemons, you're going to create lemonade. This is the best step. You're now starting to think, I know what I'm going to do. I know the dimensions. I know the attachments. Is my aligner velocity appropriate to this treatment? For example, in an adult case with a lot of derotation, I know the accuracy of my treatment plan is about 40 to 50%. So do I need to slow down that movement to perhaps enhance predictability? Which teeth are unmovable? If you have third molars present in the arch in an adult, I highly recommend to make them unmovable. Are they implants, crown teeth? Can we move them? What about phasing? Should we have to consider first creating space, then derotating, as in case of butterfly incisors? Or should we distalize first and then retract our overjet into a class 1? So these are, again, questions you've got to pose for yourself in each case. What kind of aligner product packages you're using? In Spark, for example, there's 2 different aligner products, TrueGen or TrueGen XR, which is more rigid. What kind of package you need? How many aligners you need? Err on the side of always going more. So I would always say, as a rule of thumb, go comprehensive for most of them. Right. We also need to be specific and detailed with the technician. We need to start good habits of thinking before just uploading that scan you just took and some photos and letting Invisalign, Spark, and Angel Align do their thing, and somehow giving you an algorithmic, robotically generated, computer designed plan that is not biologically plausible. So you have to get in a good habit of thinking before uploading. Do this for every upload, whether it's the initial one or a refinement or revision. You have to set parameters of what you want to do. Set up your doctor clinical preferences. Now you can ask your rep so that you get the default protocols for certain movements. And I love using the visual superimposition tool so I can see where's my T1 initial and T2. And I use that a lot. It's very beneficial to get a visual of what's happening. So I hope you enjoyed this little lecture on my 9-step checklist on how to maximize and juice that clinical plan for maximum efficiency and predictability. So whether it be Angel Align Spark or any other aligner product, Invisalign, any other aligner product, having good habits, good systems on how you order that treatment plan or how you communicate with the technician on that orthodontic plan is very important. I hope you enjoyed it. Please leave comments below and I'd love to answer any questions. Thank you. Bye.